Patient education. Successful patient education begins with empowering patients to accept the illness. Talk to them about their illness. Give the facts of the illness. This sometimes will help patients realize that this is true, that they do have this illness. Decrease hospitalizations. So through patient education, for example, a heart failure patient, we would educate them to decrease their salt intake, decrease the amount of water they are drinking, to minimize their fluid retention, and to minimize those hospitalizations with heart failure. We involve the family when possible. We have to ask the patient, though, if that's okay. We need to make sure we have proper HIPAA forms signed to have patient family involved. If we are talking to a family member over the phone, we do need that HIPAA signed prior to any conversation. And we use a holistic approach. What do I mean by a holistic approach? This here is the holistic model. We include 5 different aspects of a person's life when we do patient education. So sociocultural, spiritual, social, physical, and psychological. Factors affecting patient response. So emotional effect of the disease. The emotions of being first freshly diagnosed with cancer. That can be very overwhelming. That can be very daunting. The fear factor. So emotions sometimes will play a part in whether they're able to retain the patient education information. Social impact on family and employers. Are they willing to support the patient? A good example of this is somebody who is severely obese and needs to go on a special plan, a special dietary plan and physical therapy or those aspects going on a plan, but does the family support the new dietary changes? It's hard to be the only one to eat healthy in the house when everybody else is eating junk food. Intellectual impact. How much education have our patients had? Many times, and we don't see this as much now, but there are many older people who only have a 6th to 8th grade education. So their reading level, their interpretation level is lower than some of our other patients. So we have to consider that. There's also patients with mental disabilities that we have to consider their intellectual capacity. Economic impact. Can they afford their medications? Do they have the resources they need to take care of themselves, to better their health? Spiritual impact. Sometimes our religious beliefs will oftentimes get in the way of treatment. A good example is a Jehovah's Witness will not get a blood transfusion. It's against their religion. The 5 stages of grief. So denial and isolation is the first stage. Anger is the second stage. Bargaining is the third stage. Then they usually go into a depression. And sometimes the depression phase can be long-lasting, but it's important as healthcare workers to identify that and get them help. Because if we get them through that phase, more times than not, we get to the acceptance stage and they're willing to do something about it. They're willing to seek treatment. Perception of the disease versus actual state of the disease. Previous life experiences can influence a patient's perception of the diagnosis. For example, diabetes, there are many levels of diabetics. Some are not as severe as others. Some people can monitor their diabetes with just oral medications. Others have to be put on insulin to help manage their diabetes. But what happens is my friend doesn't have to take insulin. Why do I? Or I've never had to do that before. Why should I now? Or, well, my mom never had to take medications. Why do I? Why is it critical? It's all those why questions. Why do I have to if somebody else didn't? Or, well, my previous doctor said I didn't have to do it. Why do I have to do it now? Does the patient recognize and accept the seriousness of the diagnosis? And does the patient overreact to potential disease risks? Sometimes when you tell patients they have a certain disease and can cause another disease, like diabetes can cause neuropathy in the lower extremities, and there can be foot issues, so it's really important to take care of your feet. In that patient education, what do you mean I'm going to have neuropathy? They get really defensive and oftentimes overreact. So patient's needs for information. So perception of impact of disease on his or her general health also determines need for information about the disease. Encourage patients to take ownership of the learning process. And if they get defensive in this learning process, it's our job to really state the facts, reiterate that if you do the right things now, these things won't happen. Patient's age and developmental level, adapt the teaching plan to meet specific learning needs. Be flexible and creative in providing learning opportunities that support the physician's attempt to educate the patient. Oftentimes, your time is maybe allotted to go over glucometer testing, but your patient has a lot of questions about foot care for diabetics. What you would want to do, even though you only have a set amount of time to get that patient education, you don't want to ignore the patient's concerns. So what you do is you address those concerns briefly and what their questions are, and then you go on to what your patient education piece was, the glucometers. So say we would do the diabetic foot care, answer the questions they have, and try and keep that as brief as possible, and then we would go on to the glucometers and our actual teaching that way. That way the patient feels like we are not ignoring what their questions are, and we are trying to best fit their needs. Patient's mental state and emotional stage. Oftentimes, patients frequently use defense mechanisms to protect themselves. Be sensitive and adapt teaching interventions as needed. If you have somebody who is very emotional or very anxious, you might want to keep patient teaching as brief as possible. Give them what they really, really need to know, and maybe follow up on it and do more patient teaching in smaller sections. Guidelines for patient education. Provide knowledge and skills to promote recovery and health. Encourage patient ownership and participation in teaching process. Include family and significant others in education interventions with patient's approval. Promote safe, appropriate use of medications and treatment. Encourage patient adaptations to healthy behaviors. And provide information about assessing community resources. Influences on multicultural and diversity factors. Be aware and sensitive of the impact of these factors on patient learning. Is language an issue with the patient? Even for some patients who might be able to speak English, if that's not their native language, oftentimes they will hear it in English, then convert it to their native language, and then interpret the information. So it can sometimes be difficult, and it's a longer learning process for them. Do patients' cultural, ethnic background, or religious beliefs influence the way he or she perceives the disease and the role of the healthcare worker? So in the case of the Jehovah's Witness, we would state the facts and the risks of potential reactions, death, dying, that sort of thing if they don't receive that blood transfusion. or other organ system failures because of not an adequate blood supply. So stating the facts is the role of the healthcare worker, telling them what might happen if they don't receive or do what we are trying to educate them on. What strategies or techniques might minimize patient education problems? A lot of times if you have a variety of techniques in the way that you present the information, so an oral technique, so verbally telling them, maybe have it written, and if they don't speak the same language, have it in their language. And then demonstration. Having all three of those techniques help enforce what we are trying to educate them on. Are community resources available that could facilitate the patient learning? So the medical assistant needs to be aware of community resources that we could potentially get that patient to help them with their disease. Approaches for language barriers. So address the patient by the last name. Be courteous and formal in communication. Use gestures, tone of voice, and facial expressions and eye contact to relay a message. Use pictures, handouts, models, and other visual aids. Monitor patients' body language, especially facial expressions. Use simple, everyday words. Don't use medical terms. Don't use terms that might be over a 6th to 8th grade reading level. Demonstrate all procedures. Implement the teaching plan in small, manageable steps. Give patient written instructions for procedures and treatments, and use an interpreter when they are available. Patient learning style. Individual learning styles affect the patient's understanding. Ask your patient how he or she prefers to learn new material, so either verbal, written, or demonstration. And then develop your teaching based on their feedback. Patient with vision loss. Alert the patient that you are in the room and identify yourself. Patient is unable to pick up on your body language. Use clear, concise language and a normal tone of voice, and provide all written material in large font if they have a vision loss. But if they are totally blind, we are going to want to give all verbal instruction. Patient with hearing loss. Allow patient to see your mouth. A lot of times patients with hearing loss will try and read your lips, so make sure you expand your speech, you enunciate and you pronunciate, and that you speak slow enough where they can interpret what you are saying. You may need to touch the patient slightly to gain attention. Observe body language for understanding and confusion. Use gestures or demonstration. Clearly print any information needed to clarify, and provide written handouts. Also request that the family assist in the verification that the patient understood. Another thing that you can do is in your demonstration, have them demonstrate back what you just showed them. Patient with language barriers. Determine whether patient can read or understand English. If possible, have an interpreter or a family member present. A lot of facilities in the central Wisconsin area do not let family members interpret for the patient. And the reason being is what is being said by the healthcare provider, we don't know if the same message is being given to the patient. Sometimes a family member might misconstrue what the healthcare provider is trying to tell the patient, and we have no way of verifying that they actually got the information that they needed. And a lot of times, many physicians will not allow family members because we're not sure that if the patient complains about a symptom, that the message relayed by the interpreter is what the patient actually said. So many facilities are going to not having family members interpret. If available, use a dictionary that translates as many words as possible for patients. There are a lot of online translation resources out there that you can use that can translate our English to whatever language we need. So that is a very helpful tool that medical assistants might need to use. But for the most part, healthcare facilities in the central Wisconsin area have the resources in English. They have them in Hmong and Spanish because those are very prevalent in this area. Use gestures or demonstration to get the message across. Carefully observe patients' body language to determine level of understanding. And order education materials in patients' native language. Develop a teaching plan, consider what the patient already knows, assess the patient's needs, go on to new material that is causing the patient's most anxiety. Begin with basic details about the disease and add more information during each patient visit. Take advantage of every teaching moment. So while you're taking a blood pressure, or you might be doing a procedure, while you're wrapping up somebody's wound, you might do patient education and how to care for that at home. Use waiting room as a place for learning by providing up-to-date educational materials such as a pamphlet, magazine, that sort of thing. Implementing the teaching plan, conduct lesson in a quiet area away from distractions, so not in the waiting room. Assemble equipment the patient will need. Present only material skills it is possible for the patient to master before the end of the appointment. Restate, repeat, and rephrase the materials. Evaluate teaching plan throughout the process. Get that feedback from the patient, whether they understand, have them repeat what you just said, or maybe demonstrate what you just showed them. Guidelines for educational material should be written in lay language at the 6th to 8th grade level to promote general patient understanding. We do not use medical terminology in our patient pamphlets, or very little. Information should be well organized and clearly described. All materials should be checked for accuracy. Handouts should be attractive and professional, and copies should be available in other languages when possible, in large print. Role of the medical assistant: reinforce physician instructions and information. Encourage patients to take an active role in their health. Use each patient interaction as an opportunity for health teaching. Keep information relevant to the patient's need. Establish and maintain rapport with the patient. Communicate clearly. Be sensitive to the patient's learning factors, and modify the teaching plan as needed to best meet the needs of the patient.